Today we're going to be discussing trauma assessments. We're going to start from what our dispatch information was. We're going to go through our scene size up, and I'm going to take you through a full body assessment and reassessment. This will be for an adult patient. I will talk you through every single part of it, and I'll show you exactly what I want you to do every time we go through it in class. So we know our primary components of assessment. Start with our scene size up. Starts with, is my scene safe? Are we going to a car accident and do I have someone blocking traffic for me? Or is the car on a hill? Am I going to some type of altercation where someone was stabbed or shot or something like that? Is there police on scene that have taken care of the threat of another injury occurring to either me, my partner, or another patient? So we need to think about that. We need to think about how many patients. How many times do we all get in the car together and there's 7 of us in a car? And am I going to have 7 patients? Am I going to have 1 person in the car? Am I going to have 4, 3? I need to know those things so that I can call for additional resources and I know what I'm looking for when I get there. I need to figure out who's the most severe and who can wait a second to be treated here in a second, or they need my immediate attention. Also, what our mechanism of injury is. So, grandma that fell walking from her recliner to the bathroom technically is a trauma. She's not going to be as critical as if we went to a stabbing or if we went to a high velocity motor vehicle accident. So all of these things are going to play part into our assessment. We're then going to go into a primary survey. We're going to look at our ABCs and our X and treat any life threats. You can't move on from your primary assessment until you do all of those things. We'll then go into our vital signs and our reassessment, and we'll move on from there. So I am going to show you all of those things. I have a doll of my daughter's, but we are going to go with it is actually an adult and it is not a child. So we're going to say that I was dispatched, that dispatch information you just saw. We got turned out to a single vehicle, motor vehicle accident with 1 patient. So I need to know what kind of highway I'm on. Am I on a back road that someone might come flying around a corner and hit me? Am I on a major highway? All those things. We're going with our scene is safe. I'm going to have my BSI on. I'm going to put some gloves on before I get to the scene so that way I know when I get out, I can go and treat my patient. I'm going to be looking for things like, is the car off? Are the airbags deployed? Things like that. So pull up on scene. Here's my patient. We're going to go with our patient is responding to us. As I approach my patient, I'm going to say, hi, my name's Kim. I'm a paramedic with EMS. If they can respond to me, if she's talking back to me, I know her airway's patent because she's talking. I know she's breathing because she's talking. I'm going to reach down and feel for a radial pulse. If I feel for a radial pulse, I know at least our blood pressure's between 80 and 90 systolic, which is great. If I don't feel a radial pulse, I'm going to be concerned about massive blood loss. I'm also going to be taking in the appearance of her skin. Is she pale? Is she, do I see any massive hemorrhage coming from anywhere, anything like that? I don't see any massive hemorrhage. I reach down, I have a radial pulse, so I know that her circulation is good. Do I see any major disabilities? So things like this is going to be bones sticking out, deformed anything, large lacerations, anything like that. I don't see anything on my patient, but that doesn't mean that she doesn't have a life-threatening illness. We're going to have to expose her. So Due to the mechanism of injury, we had a single vehicle accident. I need to know if she has any neck or back pain before I move her. I will have one of my additional resources, probably a firefighter, hold C-spine for me to make sure that we're not moving her neck at all. Once we have someone securing C-spine for us, we are going to check for all of our other extremities. With my gloved hands, I am going to palpate the back of her neck. I'm going to ask if she feels any tenderness. I'm going to let her know anywhere I touch that hurts more than normal. I need you to let me know. I'm going to slowly walk the back of her neck and see if there's any step-offs, deformities, anything I see. I'm going to go, after I finish the neck, my firefighter is going to hold C-spine and we're going to roll our patient to the side. I'm going to do the same thing all the way down her back, feeling for any step hops or deformities. I'm going to expose the area, make sure that there's no major bruising or wounds that I see. And then we're going to roll her back and we're going to place her on a spine board when we do this. So when we have our patient up like this, we're still maintaining C-spine. Someone's holding it for us. I'm going to slide my spine board up underneath her back and roll her back onto it. This is the easiest way and the safest way for both her and you. Once we've checked our back, we're going to look at our arms. We're going to expose them, make sure there's no injuries. We're going to expose our chest and our torso. We need to make sure we know whether or not our patient had a seatbelt on or if they were unrestrained. This makes a huge difference. Our restrained passengers, yes, we can hit our head, things like that, but our velocity is not going to be as strong because our seatbelt's going to stop. But we need to look for things like seatbelt signs. So for our driver, it's going to come from our left side down to our right hip and then across the hips. A positive seatbelt sign is bruising in any of these areas. It's especially important that we know bruising across the hips if they were wearing their seatbelt properly. If they didn't and it's higher, we can hit things like our spleen or our liver, which will cause a lot of internal hemorrhage. So we're going to look for that. While we're here, we're going to listen to breath sounds. Make sure that we have good bilateral, equal breath sounds and she's moving good air. We already know she's breathing. We already know she's got a patent airway, but we got to make sure that her lungs are also moving the air and that we don't have some type of chest injury that is causing something like a pneumothorax or a tension pneumo even further down the line. We're going to check our pelvis. We're going to rock and tilt, and we're going to feel for stability. If our hips are not stable, we need to splint them right away because that is a place for massive blood loss. We know she has a radial pulse, so if our hips are unstable, we need to splint them quickly so that we don't have any massive hemorrhage and lose blood and lose that blood pressure that we already have and send her into some traumatic shock. We're going to move down the legs. We've already looked at the back of them a little bit when we had her rolled up on her side, but it's important that you feel all the way around her leg and encompass it completely and make sure you're feeling for any crepitus or you're feeling for any kind of things that move that shouldn't be moving. We're going to get down to our toes. We're going to feel for a pedal pulse. We're going to make sure that she has good distal pulses everywhere. We're also going to make her wiggle her toes and push against our hands and pull against our hands. What we're doing here is checking for good PMS, which is pulse, movement, and sensation. So, like I said, we're going to have her tell us if anything hurts more than normal. But when we get to like the feet and the hands, we're going to make sure that we're also checking to see if anything feels different, like she can't feel us at all, or she feels numb, or it feels tingly, or one side feels different than the other, because this could tell us that we might have a spinal cord injury of some type, which is why it's really important that we put her on the spine board to protect her spine more than we already have. Once we've done all of this, We've got our patient packaged. We're going to take a good set of vital signs. I know that I felt this radial pulse. I didn't count it when I first felt it. I felt to see if I felt one and that she had a good steady heart rate. I need to go ahead and get a pulse. I need to get a good blood pressure. We want a manual blood pressure on our trauma patients. Well, all of our patients, but especially trauma patients, because you need a good accurate starting point. We're going to go ahead and put her on the 4-lead just because we can, and it's not going to hurt anything to go ahead and look at her EKG a little bit. We listen to breath sounds as we examine the chest, which is part of our vital signs. Make sure she's moving good air and has equal breath sounds on both sides. We're also going to get a pulse oximeter and check her oxygen saturations to make sure that they are where they want them to be. We want to be at least at 94% or above. If we're not, we're going to go ahead and put her on some supplemental oxygen. Now that we've finished that primary survey of her entire body, we can go back and we can ask our sample questions and our OPQRST. So our sample questions, our signs and symptoms, what's hurting our patient? We're going to ask her, we're going to say, are you hurting anywhere? Or where are we hurting? Can you describe it to me? We're going to go with she has some back pain. Completely normal thing for an MVA. So her back pain, and we're going to ask her, is she allergic to any medicines? Because if we want to help treat this back pain, we got to know what we can give her and what we can't give her. We're going to ask what medications she takes and if she's taken her medications today. We're going to ask for any pertinent medical history. Does she have a history of seizures? Has she ever had a stroke, high blood pressure, heart attack, anything like that? And anything that she might take those medications for. We're going to ask her when her last oral intake was. If she does need to have surgery, it's important for the surgeon to know that. Also, it'll help us when we look at her blood glucose to kind of know, like, oh, that's not right. And then E, we're going to look at the events that led up to this. When we talk to her about her back pain, we're going to ask our question, was your back hurting before this accident or did it start afterwards? Is anything making it worse? Did you try to move before we got here and it made it worse? Does it radiate anywhere? Yeah, it's in your back, but does it radiate down your legs? Does it radiate down one arm, both arms? What's the quality of it on a scale of 1 to 10? And I always like to ask my patients on a scale of 1 to 10, with 10 being I ripped your arm off and hit you upside the head with it, because we all know that we get those patients that'll say, well, I'm a 30 on a 10. We need a realistic number. We're also going to ask how to describe the pain. We're going to ask if it's a stabbing pain, if it's dull, if it's a pinching pain, anything like that. Once we have that, we're going to start from the beginning and we're going to reassess everything. So we know that we have a single car MVA, that our patient was restrained driver, airbag deployment. We need to think about what destination we want to go to and we need to transport. Single car, if she lost consciousness, we need to go to probably a level 2 or a level 1 trauma center. If she didn't, we could maybe go to a level 3, just depending on what it is. If she's just complaining of back pain, she could probably go to a level 3. While we're transporting her, we're going to start our assessment again. We're going to start with airway and make our way all the way back through. We're going to make sure we don't have to roll her again unless something comes up that makes it necessary. Since she is on that backboard and in a C collar, it's probably not necessary for us to flip her again. We're going to continue to reassess her until we get to the hospital and we're able to hand off report to a nurse or a doctor that's there.